Good afternoon or evening, depending on where you're at. This is Dr. Goodman. This is Doc Talk Live. This is actually my second take at this. Ray, welcome.
Hi, Brad. Can you hear me?
Yeah, I can hear you. Great. That's working better. So, Dr. Baker, you're in California, right?
I am. San Clemente.
San Clemente. Now, where is that near?
It's South Orange County.
It's near San Diego?
It's exactly halfway between LA and San Diego.
Okay, I was just curious. Dr. Baker and I go back many years, too many years to actually disclose or divulge. And Ray, I've asked you to come on to talk about back pain today, low back pain, share some insights, but mostly I just want to have a conversation with you. Dr. Baker is really an expert on the subject. He is a past president of the North American Spine Society, and he is currently the chief medical officer. Am I saying that right? Chief medical officer?
You are.
Okay. Of a company called Redefining, which has an incredibly novel procedure, which we'll get to alleviate certain populations of patients that have chronic back pain. And so that is a very exciting technology that I hope to ultimately share with the audience. But like I said, Ray, I really just want to talk to you. You're one of the people that think about things and have a thought process involved when it comes to spine care. And spine care is just one of the most, controversial areas. And the way I like to sort of put that out there to the lay people is if you have a heart attack, you go to a cardiologist. If you have a stroke, you go to a neurologist. If you have an ulcer, you go to a gastroenterologist. If you have a kidney stone, you go to a urologist. I can go on and on and on. But if you have a back attack, you literally could go to a chiropractor, an internist, a family practice doctor, physical therapist, a neurosurgeon, an orthopedic surgeon. I mean, the list goes on and on and on. So it seems to me that there is no general consensus when it comes to back pain as to who has the expertise. And first, I'm just going to let you comment there. I'm just going to leave that statement out there and see how you would comment on that.
Yeah, I think, Brad, you put it well. The problem with low back pain, I believe, is twofold. One is that we're not very good at making a diagnosis. So that it's sort of like if you're going to treat pneumonia and you don't know whether it's a viral pneumonia or bacterial pneumonia, you're just going to treat it. And because we don't have a very good diagnosis or way to diagnose different kinds of low back pain, we end up sort of treating them all the same. And predictably, we get pretty poor outcomes with that. The second problem that we have are sort of not very good diagnostic tests that lead to that problem. So that while the rest of the world in medicine has moved on to using more objective findings, and I'll use your examples. If you go and you have a heart attack and you go see a cardiologist, they're going to do an angiogram and they're going to, squirt dye and they're going to see exactly what your coronary arteries look like. In our field, we make diagnoses either by numbing something or provoking something, which if you go back to that cardiology example, it would be like if the cardiologist put a balloon in your artery and blew it up to where you had chest pain and said, is that your chest pain? Does that feel like your normal chest pain? And yet we live in this world. Instead of moving on like the rest of medicine has towards more objective diagnoses, we still live in this land of numbing something and having a patient subjectively tell us if they're better.
In a way, that's a good segue to my next question or comment from you. But before I do that, I forgot to mention that there are anesthesiologists that also treat back pain. So I listed all these various experts, and Dr. Baker, you're an anesthesiologist by training.
I am.
Correct? So and that's why you are sort of used to that sort of paradigm of trying to anesthetize the structure and seeing if that alleviates pain. And so I want to get into this concept of false positivity and false negatives, because you mentioned how in pneumonia you don't know whether it's a viral or a bacterial, and so it makes it hard to treat if you don't know those things. I've noticed that there seems to be some strong parallels between back pain and COVID. And the parallel I see is this concept of you test for COVID and they're positive, but is it a true positive or a false positive? Or if you test for COVID and they're negative, is it a true negative or a false negative? It seems to me that COVID testing is fraught with the same problems as we are confounded with when we try to evaluate somebody with back pain. So I have a feeling that you have a much better clarity on how to explain that to the public than I do. But these are very important concepts when it comes to COVID and when it comes to back pain. So I'm very curious as to your thoughts there and how you would articulate this to our viewers.
Yeah, I would say a couple of things. One is that whenever you have a subjective test and you're relying on someone for direct feedback about how they feel, there's always a chance of a placebo. There's always a chance that someone will feel good even if you inject saline into their back.
Sorry.
And we know that placebo effect is upwards of 30% or more, meaning that 1 in 3 people that you inject their back and they'll get up and say, oh, I feel great, even if you just injected water. That doesn't mean they're crazy. It doesn't mean they have some psychological issue. These are normal people, but they just happen to be prone to a placebo effect. So the problem with that is if you just use the outcome of that test without doing further testing, you then start to go down the wrong pathway and you treat the patient as if they have the problem and they really don't. In most cases, we tend to look at what we call pretest probability, and just that word is sort of mystifying. But what that means is that a test is more accurate if you select out people more likely to have a disease. So as an example, if you test anyone who does not have any symptoms of COVID, you're likely to produce many more false positive results. If you only select out those people who are sick, have a fever, have a cough, etc., that percentage of false positives goes way down. But in our world with low back pain, we tend to not do that very well clinically. And we treat one size fits all. We sort of put people down an algorithm, irregardless of their age, irregardless of a number of other factors that we could take into consideration. And we just sort of do the one size fits all treatment.
So your company has in a way, your company has almost redefined back pain. Maybe we should start there. Let me back up for our listeners and just say, hey, when somebody comes in with a back problem, there are many potential sources of pain from the spine. It could be the facet joints. It could be the disc. It could be the myofascial structures. It could be the sacroiliac joint. There are a lot of different structures that can cause all the same symptoms. But your company has actually redefined back pain and has found a segment of the chronic back pain sufferers with what you call vertebrogenic pain. So maybe it would be worthwhile to give us a little perspective on that, because that's that in and of itself is a huge leap in where we are with back pain. Huge, huge.
Yeah, you're right in that we have these major categories that we believe cause low back pain. You know, there is the disc, the facet joint, the sacroiliac joint. There are muscles and myofascial type pain that can cause all can cause back pain, and there are other sources of things that can cause back pain. But those are the major four sources that are discussed. For many years, we grappled with discogenic pain. And we grappled with it because it was presumed to be the largest cause of low back pain. And yet, all the treatments that we had for discogenic pain didn't work very well. You know, we did everything from doing IDET procedures, we injected steroid, we injected, you know, all kinds of biologics into the disc, we fused the disc, we did total disc replacements. And yet the outcomes from those treatments really were not what we would have expected. People did not come out at the other end of treatment with the degree of relief that we would have hoped. So we always had this nagging suspicion in the back of our mind that there was something else that we were missing. It's not just discogenic pain. There's got to be something that we're missing about that. So one of the things I'm proud of about the company that I work for, Relievant, is they've taken a very scientific approach to this. They built their product based on the science of where the pain is coming from. And it was actually sort of a mistake, if you will, about how the answer came. And that one of the scientists that was looking for nerves in the disc found many fewer nerves in the discs than he thought. And he thought, well, this is not right. You should have had many more nerves in the disc if this is the number one cause of low back pain. But lo and behold, he did the research again, took the samples again, and they had very few nerves. So then he thought, where are the nerves coming from? And he looked at the end plate on each side. The end plate is essentially the bread in between the meat. If the disc is the meat, and the bread on each side would be the end plate. So Brad, you probably have a
I
model.
do. I just hate for us not to have visuals, so yeah. I'm going to hold it up a little bit.
So the vertebral body is the vertebrae is the main structural support for the back, and in between each vertebrae is that cushion, the intervertebral disc, that allows for you to move and also allows some shock absorption, if you will. So while all the research and time and treatment was spent on the disc, it ends up that the end plate, that bony surface on each side of the disc, actually is a far richer source of nerves. So that was a surprise to us. Everyone thought, well, it's got to be the disc, and indeed it was the structure adjacent to the disc. So we've been looking sort of in all the wrong places for pain. Not to say that the disc is not a source of pain or could not be a source of pain, but we had missed a structure that is a far richer source of pain that was lying just adjacent to it.
So take the story further, Ray. What happened next? Give us a little historical time frame. So first, somebody, are you saying that he accidentally or serendipitously, somebody sort of figured out, we need to look at this differently? Then what happens?
Well, the original idea came from Michael Hagenes back in the 1990s, where he was looking at the fact that when we do discography, when we put a needle in the disc and put pressure on it, we deflect the end plates. And Dr. Hagenes believed that the end plates could be a source of pain. Previous to that, it was always felt that the bone itself could not be painful. Only the area surrounding the bone was painful. So the work in his lab at Baylor actually showed that there were pain-sensing nerves inside the vertebral body, and that was how this started. It then moved on through UC San Francisco with Jeff Lotz and others, and he was looking on a whole different experiment about nerves in the disc and found that the end plate is actually far richer. So two independent labs came to the same conclusion, if you will.
And then who had the idea, let's just do a root canal?
That would be Dr. Hagenes. I can remember I was on the board at North American Spine Society, and he was as well. And he came up to me and he said, I have this kind of crazy idea that the end plates are actually the cause of pain. Actually, I thought it was a pretty crazy idea back then, too.
Isn't that interesting? Your reaction to it was that it was a pretty crazy idea, yet now, now this consumes your life.
Yeah, I mean, you know what you know through medical school and fellowship and training. We're all trained to think of the common sources of pain, and it's sort of the dogma that we're taught.
Right.
Then
that gets back to COVID again. I hate to make this announcement, but this is why I wanted to talk to you again, Ray, is like on Facebook. This is on, by the way, we're on Facebook, just so you know. But like on Facebook, you can see all the passion of people saying, oh, you shouldn't wear a mask, you should wear a mask, this, that. What do you think of COVID? Will there be? I don't know. I'm very agnostic when it comes to it because it's not my area of expertise, and I'm not reading the original research, and I don't even know if I'm I'll just say smart enough, for lack of a better word, smart enough to really decipher the source information. So what everybody does is they turn to an authority who they think has read that information for them, who then puts out an opinion, and then you're like, well, Dr. Fauci says this, and so, but I have not digested the source material, and so it's hard for me to really know. I tend to do what you did when Dr. Hedgenes told you about vertebrogenic pain. You were like, that's nothing I've ever heard of before. And now more and more data has come out, and it has clearly swayed you. So sorry to interrupt, but I think the story is interesting. So I'm going to ask you to continue it.
No, it is. And when we give a seminar or a talk for physicians, you can watch the light bulb kind of go off in their head. And it's mostly around the science. It's about the proof in a very stepwise fashion that first there are nerves in the vertebral body, then those nerves can cause pain, then the nerves are a richer source of pain than the disc is, and that there's a nerve that transmits that pain back into the central nervous system and up to the brain, and that if you ablate that nerve, you can relieve the low back pain. And that's the root canal kind of idea that you talked about. So it's sort of a stepwise approach. That same approach to science has gone on, and the company has done 2 randomized controlled trials to prove that concept, that if you ablate the nerve, that it's both safe and it also produces pain relief. It's not for every patient, but it is for patients with what we would say vertebrogenic pain.
So is it Dr. Hedgenes? Am I saying that right?
Yes.
So Dr. Hedgenes proposes that we should ablate the nerve. Is he the one who comes up with the technology, or goes to somebody to develop the technology, who then developed the technology, the tools, the instruments that says, right, hey, this is what we need to do? How does what's the next step in this process?
Yeah. It went through a number of different hands early on. He worked with Baylor. He worked with Johnson & Johnson. Ultimately, the company spun off and became independent as Relievant, and then had independent investors who then funded the studies and the production of the technology. So there's the idea, and there's all the time and effort that's spent taking that idea and making it something that is scalable and usable.
Because the technology is actually, it's not like I can just get a radio frequency needle, because we've done sort of heating procedures for years and years and years, but these are very special instruments that required a lot of thought in order to figure out how to really get the heating element where it needs to be.
Yeah, I think as opposed to other radiofrequency procedures that we do in soft tissue, when you're doing the procedure in bone, it has certain challenges. You first have to get the probe to the bone and to the target where you're going to ablate. And then you have an environment that's a different environment than the rest of the body. Inside the bone has its own challenges. But the company was able to overcome those challenges, produce an instrument set that allows you to make a channel to that nerve, and a probe that allows you to safely ablate the nerve.
How about we talk about how common this problem is? We sort of, said it's very complicated to, figure out back pain. There's no expert. But let's talk a little bit about the diagnostic workup, because this is, you've not only have you discovered this vertebrogenic pain and defined it and help create a nomenclature around it, but now we also have an ability to at least better diagnose it than we had years ago. So I think that really deserves some time for you to expand on for our audience, Ray.
So if you go back to the beginning of our discussion, Brad, and you talk about the fact that we have trouble defining a source of low back pain, and we have trouble diagnosing that source of low back pain. The thing that we did differently, we decided we're going to plant a flag in an objective biomarker. We're going to break the trend of saying that we're going to numb something and find out if the pain goes away, and we're going to use something objective. So the company early on, when they went to the FDA, instead of using discography, which was the technique that was most commonly used to discern discogenic low back pain, they decided to use an MRI. So the benefit of using an MRI, a routine MRI, is that if you can find a biomarker, something that shows up in that MRI that would define or be a characteristic of vertebrogenic pain, then it should be objective. It's not relying on the patient and their ability to tell you whether it's their pain. You're really able to look at an objective source to define that pain. So the company chose what's termed Modic changes. And if you think of what Modic changes are, it is the MRI manifestation of inflammation of the end plate. So as the end plate degenerates, cracks form in that end plate, and inflammation starts to occur, there are certain MRI signals that show up that sort of define that inflammation at the end plate. We call them bone marrow changes or Modic changes. And although we knew about these since Michael Modic defined them in 1988, they kind of fell out of use only because we didn't have a treatment specifically for them. So we didn't say, oh, there are bone marrow Modic changes and therefore we're going to do this to the patient. We were still in the mode of doing what we did to every single patient, putting them down that same algorithm. So the company took an existing marker and put a new treatment and a new diagnosis that was able to be defined by those bone marrow changes.
You kind of said it, though, as if they had other choices of markers to use. And so that begs the question, are there other markers that they could have chosen to hang their hat on? Because I'm not aware of other markers, and I think we need more and more and more markers.
Right. At the time, and you're talking 15 years ago, there were not. And at the time, the FDA was actually pushing quite hard to use discography. Their feeling was if you use discography, you would put pressure on the end plates and you would create pain if those implates were inflamed. We felt that that was a bad idea because discography was, again, a subjective test. As I always used to say, it's the physician's subjective interpretation of the patient's subjective experience of pain.
Right.
So it's double subjective. And there were some indications that the performance of discography might actually accelerate disc degeneration. So whether or not that's true, we felt that was probably a bad test. And still today, if you look at the use of Modic, it's turned out to be a very nice biomarker. It's very specific for vertebrogenic pain. And our clinical studies would tend to show that if you use that as the marker to define who is a candidate for our treatment, that the patients do very well.
So are there any other markers that you're aware of? I'm just interested, personally, or what's on the horizon.
If you look at the body of evidence and what's being developed, it's still the most robust evidence is still around Modic. People are starting to dig into that idea of the end plates degenerating, and they're starting to define the end plate defects and degeneration a little bit more. So that may in the future come up with be an additional way to help to diagnose this. People are also refining MRI techniques to define Modic and to quantify it. Modic is a fairly late signal, meaning the inflammation has to have gone on for quite some time before the MRI will show those inflammatory changes.
So potentially we're missing a lot of people that would benefit from your technology.
The scientists I talk to that are doing the bench work behind this believe that they can use sensitive MRI techniques that aren't yet available that would probably show up patients who would be candidates for the procedure, but yet haven't quite turned positive yet on that biomarker.
Now, would this be spectroscopy or something else?
They're using various different, anything from a high powered magnet within the MRI, a high Tesla, to using different, what we would call post-processing signals to try to look for subtle changes in bone marrow. There's UTE sequences, ultra short time to echo, and these other things that I could go on and on about. But they're specific and still in development. They're not yet all ready for pilot.
Because it's frustrating to have a patient that potentially is a good candidate for this technology, yet doesn't have the biomarker, the signal change, in order to qualify. And to pay cash for it can be quite expensive.
Yeah, and one thing, being a new technology, we're trying to produce a brand, if you will. And
Sure.
every company is branded one way or the other. And there's times that in our field of spine care, companies have sort of gone out and sold products, what I would say is a little prematurely, and they broadened the indications too much.
Sure.
And then it kind of ruins the technology.
Sure.
So what we're trying to do is first get a good reputation with the payers, get a good reputation with the physicians and the patients, and then expand appropriately as the science evolves. We don't want to get ahead of ourselves and create a problem where we're broadening indications inappropriately.
What do you think is the population out there with this problem? Can you estimate it? I mean, we've heard chronic back pain affects X millions and millions of Americans, for instance.
Yeah.
But break that down. What do you think the real population is that would benefit from this therapy?
Right. So if you look in the United States alone, not outside the United States, but if you just look at the United States, chronic low back pain defined as low back pain greater than 12 weeks, it would be about 30 million people. Somewhere between 10 and 13% of the adult population in the United States have chronic low back pain. So we hired a company that digs into research to try and define better exact populations of patients. And they poured over 104 different articles. You know, some of the authors that I had them call. The people who've done the studies, Michael De Palmas of the world and others. And we said, call them and source out exactly what the population is. In a very scientific way, they got down to it. And we are indicated for about 1 in every 6 of those chronic low back pain patients. So that would be about 5 million people.
1 in 6 people with chronic low back pain. That's a very large percentage.
It is.
One thing we haven't done is we haven't really shown the technology. I'm not sure, I have a video that y'all have, and what I'll do is I'll try to put that video on the Doc Talk page. I would love to show that video. Let me see how share screen works. I'm just going to play with this for 1 second, see if I can do this. Okay, it says your entire screen. I don't think I can do this, but I'm going to try. Huh. I don't think it's working. What do you see? Do you just see me still?
I just see you still.
Hold on. Show and stream. Okay, now what is that? Now you see a little blue thing?
I do.
Okay, let's see. Now, do you see the Relievant video?
No.
You don't see that? No. Anyway, I love this video. I'm gonna have to put it. On the website under a separate thing. But just talk a little bit about the procedure, and we'll call it there, Ray. So tell us if you have any models. Great. If you don't, that's fine too. But just tell us a little bit.
I don't. I wasn't expecting to be going this deeply into the technology, actually. So the technology itself is a minimally invasive procedure done as an outpatient. It uses an approach that would be a common approach to get into the bone, into the vertebrae. Then a channel is created through the bone into where that nerve is. It sounds like a bigger procedure than it is. It's really a fairly routine procedure. You've done the procedure, Brad, so you know. It takes about an hour to an hour and a half, usually done under either a general anesthetic or under what we call a monitored anesthesia care or a sedation. Patient goes home immediately after the procedure. The people normally within 1 to 2 weeks start to note the improvement in their low back pain. That would be, probably the easiest I could say. We place a probe into the middle of that vertebral body where the nerve resides, and we heat up the tip of that probe, if you will, to create a lesion and stop the nerve from regenerating. One thing I'll mention is that as opposed to other radiofrequency procedures where the nerve grows back, with this procedure, the nerve doesn't have the capacity to grow back. So the good news is that we now have 5-year data showing that the people actually are doing better at 5 years than they were even at 1 year. So they continue to improve over time.
I appreciate that explanation, Ray. Are you traveling yet, or are you still locked down?
No, I've been traveling. It kind of comes in fits and starts. I was traveling a lot last week. Made some trips out to do physician trainings and other things. This week I get to be home. But yeah.
Any thoughts on COVID from a scientific sort of thought-based? Because again, it's like all over the map.
Right.
Any thoughts there? How do you process COVID?
Yeah, I guess I would start where you started, and that is, I'm not an expert. I certainly do the reading as you do the reading, but the interesting part about the world today is the basic academic research has been turned sort of upside down, right? And that we no longer are going through the normal publication patterns. Things are put out right away.
Yeah, Doc Talk Live, hopefully.
Yeah. So it ends up that people can follow in a pretty concise manner and keep up to date as well as you or I can keep up to date. So I'm not. I don't think I have any special insight. I think
I think your special insight is that you have studied back pain and understand the sort of the pitfalls, and those pitfalls are the same in COVID. Those pitfalls are the same in everything, So you have a perspective from a rigorous research, let's say, mind. I guess that's where I'm getting at with that question.
right, right. I think we've learned that this is not going to be a short pandemic, and we're moving into sort of a different phase. I know from a company, we initially pulled way back as the United States pulled way back, and physicians were offline, they weren't doing procedures. What we're noticing now is it's sort of what I would say is sort of like fighting a forest fire, where you can't actually put out the forest fire, so you're containing the hot spots and you're applying resources to where the fire is getting out of control to bring it back in control. So, the one insight I have is that we can follow the company all over the United States and get a pretty good pattern for where physicians are doing treatments, not doing treatments. Patients are comfortable going into the hospital, they're not comfortable going to the hospital. And I think we're moving into kind of a longer phase battle with this virus, and it's going to require intermittent shutdowns in various different regions of the country, while other regions may go on a little bit more normal, COVID normal, not by any means normal.
Somebody has written in with a question, and it's a marketing question, Ray, and I think it's interesting, and I'm going to read it. Can you see it on your screen?
I can.
So it says, is there anything I can do to get this going in my practice? So Jonathan is a former fellow of mine, so he knows about the technology. I've been working with the Nashville rep, but I'm still having trouble getting it going. Any advice? So I'm going to start with my answer, but then I want to hear your answer, because it's what you're dealing with, Jonathan, is once again, patients with chronic low back pain don't have a backologist to go to, like they have a cardiologist or a neurologist. It takes us full circle. So there is a huge lack of awareness for what you do as a interventional musculoskeletal and spine specialist. You don't exist in their lexicon. And furthermore, Jonathan, this technology doesn't exist. It's not big enough. It's not, y'all don't have the marketing yet in place where people know, hey, I've got chronic back pain. There's a 1 in 6 chance that I would benefit from this procedure. That level of awareness just does not exist in the public. And so that's what you're up against. And so you have to do things to educate your community. And so what I would recommend, Jonathan, is that you talk to chiropractors, you talk to physical therapists, you talk to primary care doctors who are seeing chronic back pain. You even talk to surgeons who really are very unlikely to operate on this segment of the population. You're really not taking away cases from them. And you've got to do a lot more outreach to reach those people so that there's awareness, or do something, with your local news or something like that. Ray, how would you expand that? Because you were in private practice for 20 some odd years too. So I'm sure you're well aware of the frustrations of not seeing the patients you want to see that you can help.
Right. You made a number of really good points that I would amplify on. One is that we're having to educate the public, and that means physicians, insurers, government, patients, on a whole new source of pain. And that in and of itself takes time because people are initially skeptical. They go, what do you mean the vertebral body hurts, right? But then they get over the skepticism, and then you say, well, we have a whole entire new treatment. So you have kind of a double hurdle. You first have to convince them there's a new source of pain. Then you have to convince them there's a new treatment for that. Fortunately, we have a lot of evidence behind this. So we have 5-year data, we have 2 randomized controlled trials, we have a lot of very good scientific data supporting this. But the physicians who do the best are the ones that take this on personally. The ones who say, I'm going to fight for this in my community. And it's not to say that Jonathan's not doing that, because it's a tough battle with convincing the hospital, convincing, your surgical center and everything else to do that. The people that are successful, and the reason why we're doing well as a company, even through this pandemic, is that we have sort of partnered with physicians who fight the fight with us. And those people are more likely to keep going and be advocates for us. So we're having sort of our best quarters ever right now, despite this downturn. And I think it's because the quality of the physicians we partner with, and they really go to bat for us and fight for us. They go to their hospital administration. They say, listen, we need to have this here. They go and they outreach to their patients and to their referring physicians and say, this is a new treatment. Refer your patients in for it. And they do very, very well. But it's not an easy battle, frankly. It's always tough bringing something new.
Yeah, and in my story, Ray, as you well know, is I can be very skeptical too. So I'm like, I want to do the research study. I'm like, put me in the trial. I want to see if this really works. And frankly, I was blown away by the results. I really was. And that's why it's so easy for me to do a Doc Talk Live on this, because I really am familiar with the technology. I know the questions that I want to ask. But I appreciate, Ray, I appreciate what your company is doing. I think it's revolutionizing spine care. I really do. And as I told you, this is not, do not want to promote me at all. I want to promote sharing knowledge with the public. So Jonathan, put this up on your website, share this, and that will help a lot. Anything else? Any closing thoughts, Ray?
No, to me, I have the most fun when I talk to physicians and I talk to them offline, meaning I say, what are the results you're really getting? And I had that conversation with you, if you remember. I called you up on the phone. I go, Brad, I've known you for many years. I just want to know, how are your people doing? And you said, hey, this is fantastic.
And when they don't work, I call you up and I'm like, Ray, what is going on here? This was a slam dunk.
And then I said, well, does it happen often? You said, no, that's why I'm calling you. Everyone gets better.
Exactly.
But the other is that when I talk to patients, so those are the two things that are the most gratifying, because most of these people have had pain for, 3-5 years. They've been told everything from it's in their head to, they just have to keep living with it. And to see some of those people turn their lives around is actually, it is very, very gratifying. So
yeah.
it's,
and that's been my experience. So Ray, I guess I'll let you go. I love talking to you. So I hope you'll come back and talk again about whatever. And maybe I don't know. If you can show us a live procedure, we'd like that too. But whatever. Anyway,
we'll try to work on that.
All right. Thanks, Ray.
Thank you, Brad. I appreciate you having me on.
Take care. I'm going to hit stop.